All right, I'm going to try to hold two things at once. I can't stand behind a podium, so I apologize. My name is Sandeep Kapoor. I am the director of ESPER at Northwell, and I'm honored to be here today because I think it's really important. By the way, I don't have any conflicts of interest. I think it's really important that we have this conversation. I'm sorry. For the AV, is there any way to unzoom this by any chance? Because it seems like the screen zoomed in a lot. But I'm here really just to kind of help trigger some dialogue around how we need to really diversify our approach in the traditional healthcare setting around addressing substance use. Before I do that, I think it would be very helpful for us to understand who's actually here. So how many of you work in a traditional medical, surgical type of facility? Just raise your hands up loud and proud. Okay, very few. Okay, that's great, thank you, welcome. How about in behavioral health services? Raise your hand, okay. Addiction services? Okay. All right, so that's really important because I think the frame of this conversation is important for all of us to hear, particularly our medical surgical colleagues that are here. But really, I hope what you're going to hear through the conversation that I'm going to start and then hand off to our colleagues here is that there's a lot of movement around figuring out how to partner, how to break these silos that we've had for so long where theoretically substance use was only a psychiatry behavioral health issue as opposed to taking shared ownership and accountability regardless of what discipline of medicine you're in. We have multiple touch points with every single person in our community as a healthcare industry. Why not take advantage of each exact touch point to really gauge the status of how substances may be playing a role in that patient's life, how behavioral health may be playing a role in that patient's life, but more importantly, to act upon it as opposed to just ask about it. So I'm going to cover three objectives pretty much, which is one, recognize the important role of ED settings in this journey that we're on, explore avenues to diversify the traditional department's portfolio to address substance use, and lastly, I think it's an opportunity for all of us to really figure out pathways to fortify partnerships. Because the one thing that I can say with a huge sense of humility and trying to be as humble as possible, hospital systems cannot do this alone. We could sound like we can, but we cannot. We need the patient, we need the family, we need the community, we need community-based organizations. We need to figure out a way to work together the same way we would around any other chronic illness. Okay, so my wish list, and usually I present this with a group of folks, so that's why it says our, but my wish list really is to highlight some of the key factors that have brought us to where we are today, at least at Northwell, and hopefully serving as a model for others, not just outside of our organization, but primarily for inside of our organization, so that we can keep driving forward, so we can keep this momentum going, so that we don't stop because we want to pat ourselves on the back. So let me tell you a little bit about our organization and our approach. So I'm sure you've heard of Northwell, 68,000 employees strong, largest private employer in the New York area, as well as the largest health system in New York State. So if you were planning a wedding, planning a party, whatever it may be, you obviously can recognize very quickly this is a great petri dish. It's fertile ground to test things out because we have so many people. And every one of our employees tend to be our patients as well. And every one of our employees live in the same communities that my kids live in and that go to the same supermarkets that I go to. So it's really helpful to look at this as a holistic thing beyond just patient care, but this is an employee issue. This is a community issue, and what better place to start when you have this mass organization to test it out. I sit on something called the Opioid Management Steering Committee, and for many of you, you may have heard the term opioid stewardship. This is really our way as a system to really put on paper 4 simple buckets that any health system can put some strategies into so that we can better address the opioid crisis. If we were to rebrand this panel of folks that work day in, day out, volunteering their time to come up with better solutions, it would be substance use in general. Ideally, we would have one for behavioral health as well as for all the other big chronic illnesses that, unfortunately, our communities are suffering from. But I will say, when you look at this side of the screen, you see 4 simple buckets. And they are very simple. When you look at this side of the screen, you see how many touch points this industry gets it wrong. There's tremendous amount of opportunity. This is not to shame ourselves, but it's to really discover that every place that we may be getting this wrong is a tangible opportunity for us to capitalize on. So Dr. Martin Luther King said life's most persistent and urgent question is, what are you doing for others? And a room full of thoughtful healthcare professionals, easy question to answer. Now, let's remove the word others for a moment and replace it, what are you doing for folks dealing with substance use issues? And I promise you, as an industry, very difficult question to answer, and potentially even personally and professionally, difficult question for us to answer when we self-reflect on this. But that doesn't need to be true. I think everyone in this room, everybody that you report to, everybody that reports to you, we all got into this industry to help others. We just need to find the pathway to especially help folks that may be dealing with substance use issues. One of the key messages, and I think this hopefully will resonate with everyone in this room, it resonates with me, is that this conversation can't stop here, right? But it has to start here. So everything you know about substance use, you have to bring it to the forefront of your mind. All the good, all the bad, all the ugly, bring it all to the forefront of your mind, and now think about how it plays out in your daily life at work. How it plays out for your fellow colleagues, that the same conversations that we grew up with around our dinner table, where we didn't talk about this topic, where we talked about that quote-unquote drunk uncle or that kid down the street that hung out with the wrong crew, the way we talked about this has jaded us. We have been socially primed to look at this as a moral issue, as opposed to looking at it with the algorithms, the evidence, and the science that all of us have been trained to do for so many other, again, I'll say it, chronic illnesses. So my challenge to all you folks today is diversify your thinking around this. Let's have an open mindset. Clear the slate a little bit. All the challenges we faced before, again, those are all opportunities now. And if you are willing to diversify your personal approach, well then you will, through osmosis, allow others to facilitate their process to diversify their personal approach. We can draw out the best flow charts about what to do with patients when they come into our doors, the best process maps, whatever it may be, but these all fail because they're contingent on us as individuals. No matter what organization, no matter what zip code we live in, where we work, it's all contingent on us to actually play these things out. This topic in particular, like I mentioned before, because we're so socially primed to look at it a certain way, it hurts system-level processes. So our step, and I'm going to go over this a little bit, our first mission was to start normalizing the conversation around substance use, was to talk about the commonalities between substance use, hypertension, diabetes, cancer, to bring that frame of mind and reset it so that we could put the social primers aside and again start looking at it from the medical perspective. So I'm going to tell you a little bit about our strategy. It's been in a layered approach, and I'm going to describe that in more detail, but this layered approach that we've taken, we've built a foundation, and now we're just building on top of it. And I promise you, these slides, they're going to look really pretty. There's a lot of work that goes behind getting this stuff done. It looks great on slides. But the day-to-day, the one thing that we're battling is not people resisting or pushing back, it's people feeling uncomfortable. And I'm going to describe to you why people feel uncomfortable, because I think all of us have probably felt uncomfortable about this topic at one time in our life. So let's talk about a house. How many contractors in the room? All right, great. You don't need to be a contractor. We all know that worked out really well. Thank you for no one raising your hand. Just think about it. Every house needs a foundation. So for us, our foundation has been the SBIRT program, Screening, Brief Intervention, Referral to Treatment. Now, there's a lot of narrative around SBIRT. It works, it doesn't work, it's not worth it, all the stuff that you hear out there. I'm going to tell you about our strategy. This was the lowest hanging fruit for a system. All we've been asking our team members to do is to show compassion, to show empathy, and to show some concern about their patient's substance use. I'm using the word use for a reason, because this is not just about abuse. It's not just about addiction. It all starts, with use. So how do we do that? I'll go in more detail. Let me tell you about what supported the building of this house. It's the framing. We recognized very quickly, and it seems kind of embarrassing, but the reality of the equation is we recognized very quickly when we were asking frontline team members to ask 3 to 4 questions around alcohol and drugs, how much discomfort there was. And that discomfort, again, wasn't because they hate this topic, or hate our patients. They got into this business to help people. It was because we weren't educated around this topic. And I'm going to go over that. Our second layer is our NowSat program, and we're going to hear from Rebecca. The state is doing amazing work. We partner with the state on this, but really is opioid overdose prevention, talking about safe disposal and safe storage, and then obviously training people on how to use naloxone and dispensing rescue kits at point of service, in primary care, in emergency medicine, in substance abuse services, through our ambulance company. I mean, you name it, we're trying to flood our communities with this antidote for an opioid overdose. MAT in the ED, so medications for addiction treatment, that's one of our newest layers. It's empowering our frontline clinical teams that aren't the traditional psychiatrists or addiction medicine folks, our ED docs, our primary care docs, our obstetricians, to understand that there's medications to help people with alcohol use disorder and opioid use disorder. And you don't need to wait to start that treatment if you have a patient who's ready and willing. And lastly, and I'm really proud of this, it's Project Connect. We have Mary here from Central Nassau Guidance. We partnered with Central Nassau Guidance, thanks to Suffolk County, and created a care navigation network. Now, how many of you guys know someone that's ever had a knee surgery in this country? Good number of us, right? You probably know that over the next 6 months after that knee surgery that they probably got 12 phone calls. A phone call about, did they pick up their medication? They have 3 appointments. What color is the sky outside your house, right? I mean, we care manage things to the T so that we don't have readmissions, so we don't have infections. However, as an industry, you can come in reversed on naloxone and nobody's calling you day 2. Nobody's calling you day 10. No one's calling you day 30, 60, 90, or 120. We're challenging those industry standards by something with Project Connect, knowing we can't do it alone as a health system. We need community-based organizations, and we built this whole protocol where we are engaging with our patients that are willing. We're engaging with them at day 2, day 7, day 30, day 60, 80, 90, actually tons of engagement so that someone doesn't have to navigate the landscape of addiction treatment on their own. So I'm not going to belabor this point. A lot of you guys already are very well familiar with the prevalence of substance use, but this should be a realization that we take seriously. 1 in 4 people that started using alcohol, drugs, and tobacco before the age of 18 currently have a substance use issue, leaving 40 million of us, our family members, our patients, folks that live in our neighborhood, dealing with a chronic illness that overshadows the prevalence of heart disease alone, of diabetes alone, and of cancer alone. And now, I don't know how many of you folks went to medical school. Just raise your hand. Dr. Delman, come on. All right, there we go. All right. Come on. All right. Now, actually, wait. Let's do this. Let's do this exercise. How many went to medical school? Just raise your hand. How many went to nursing school? Keep your hands up, the docs, please. Okay. Now, keep your hands up if you got more than 10 hours of education on substance use during your schooling. 2 hands. Okay, more than 20 hours? Okay. My 8-year-old can talk to us about blood pressure right now. We can go to medical school and we can't talk about addiction. That's a problem. I have a slide on it in a moment, but that's a problem. Okay, so how do we rethink our approach? Because it's great to talk about it, but how do you put this into play? Well, let's take a disease process that we're familiar with, which is type 2 diabetes, for example. If we look at type 2 diabetes, we know there's a journey. Right? And we hear journey a lot when it comes to substance use, right? But there's a journey with diabetes as well. We take advantage of every single touch point, from pediatrics all the way to, elder care or palliative care. We're screening, we're intervening, and we're trying to treat so folks don't end up with the diagnosis of diabetes. Sounds fair? We do this for hypertension as well, by taking someone's blood pressure every single time that they sneeze or come to us. Okay, so can we look at substance use the same way? Part of the problem is when I say the word substance use, everyone thinks about substance abuse. We only think about addiction. However, 95% of us are somewhere around this journey. Are we really taking advantage of every single touch point that we have in healthcare to recognize this, to explore this, to support someone? But these touch points are really important. And we don't need to make this separate. We don't have to say, oh yeah, now you need to start screening for substance use and it's this brand new project. No, we've been doing SBIRT all our lives. Again, think about blood pressure. We screen, something's outside of normal limits, we have an intervention. We talk about height, weight, we talk about diet, nutrition, we talk about medications. we treat or we refer out to treatment. I mean, that's pretty much what the algorithm is, and it's programmed into our heads as healthcare professionals. We just need to put that and superimpose it on top of this disease process. So our ESPER program was our lowest hanging fruit, like I mentioned. This is how we did it. It's all about starting the conversation. The way we did it was not making it exclusive. Because we know very well for behavioral health, it's been way too exclusive for way too long. We've had multiple touch points with multiple family members throughout this industry, and we don't gauge if they're dealing with depression, if they're dealing with anxiety, and the list goes on. So if learning from that lesson, we went and got everybody and their mother that was interested in hearing us out to be a part of this. This slide is one of my favorites because it demonstrates that substance use, abuse, and addiction is a universal medical issue. Yes, behavioral health plays a big role. Yes, physical health plays a big role. But the beauty of this is that we share the accountability. We share the ownership, and we share the same motivation to get something done for that patient. So we did it in a team-based approach. Now, a lot of the things that I always hear is like, oh, the docs don't have time. The nurses are overwhelmed. And you're absolutely right. And that's in any clinical setting you go to, not just emergency medicine. Any clinical setting, because the metrics that we live by, length of stay, door-to-doc time, all these different things, they play with us. They mess with us. But if you share the ownership not only on a system level with different departments, but within a team, you'll see how you can empower your medical office assistant, your emergency department technician, your social worker, care manager, nurse, pharmacist, you name it, how you can empower them to play some role in addressing substance use as part of your clinical repertoire. We also made sure that we made it universal. So no more cherry picking, no more saying that person looks like they're dealing with alcoholism, that person looks like they're doing drugs. No, we ask everybody, every single time, built it into the electronic health record, no decision point for our team to say, did we screen last year? Did we screen 2 months ago? It doesn't make a difference. We don't do that with blood pressure. I don't care if your blood pressure was taken 10 minutes ago. I'm probably going to take it again. So we built this in so that it's universal repeat screening, again, to further normalize the conversation for our own teams, but also for our patients. I won't go over the map, but I'm really proud to say out of 18 emergency departments, we're pretty much in 75% already. And this started with SAMHSA funding through OASIS for 5 years to get this going. Our health system saw value, and it's continued. It's a budget line now. I mean, this is part of our strategy so that we can keep challenging the industry norms. One of the cool benefits or the collateral benefits that we got out of this program was what's on this slide right now. What drives a lot of the hopelessness of our communities, the families, the patients, as well as our clinical team members, is that everyone, for some reason, thanks to television, is always striving for detox and rehab. Everybody. And I don't get it. I didn't get it then, I get it now, but it's something that can be so simple to explain with blood pressure. If you have high blood pressure, you don't end up in an interventional cardiologist's office the next day. Right? I mean, I think that's pretty clear. Even if you wanted to, it'd probably take like 3-4 weeks. So why is it if someone is dealing with substance use, somewhere on that spectrum, is the only thing that we think about is rehab and detox? When there's tremendous outpatient network of care that could be a great starting point for someone. And this is where the community-based organizations come into play, because they have tons more of outpatient care than we do, but we have a tremendous amount. And what we've been doing is trying to build bridges and this knowledge base that, by the way, guys, we can start somewhere. That somewhere could be outpatient. And then trusting our collaborators that if further navigation is necessary, they're probably better equipped to understand a higher level of care, what's actually needed, social services, and so on. So this is one of the best collateral benefits of the ESPER program is now we've awoken our fellow team members to understand that there is outpatient care. There is a landscape of addiction treatment, not just rehab and detox. New York State put out a mandate, July 11, 2018. It's tattooed to my back. No, it's not. But it's a mandate telling healthcare systems in traditional medical and surgical settings, emergency medicine, inpatient, it hasn't hit ambulatory yet, that you need to do, and wait for it, evidence-based screening, that's the S. You need to do some sort of compassionate conversation, that's the brief intervention. And then you need to have some pathway towards care, which is referral to treatment. So this model was very lucky for us that we could come to compliance with the mandate, but I promise you, we're in our infancy. We have 23 hospitals. We have 18 emergency departments. We're trying to stand this up, but we need to do it, not because the state is asking us, and no offense to anyone from the state here. Thank you very much for the mandate. No offense, but really, we should have stood this up already. Okay, so let's go back to the system level strategies, because I think this is really important for everyone to see. 4 big buckets for a system to approach the opioid crisis. Okay, SBIRT hits 3 out of the 4 system buckets. Lowest hanging fruit, contingent on communication. You don't need to go to medical school, nursing school, social work school, care management school, pharmacy school, licensed mental health counselor school. It's great if you do, but you don't need to in order to hit 3 out of the 4 buckets at a system level to better address this crisis. So we use this as a springboard. I talked about framing, but let me put this to play. The average physician in this country has received less than 4 hours of education around substance use. Remember, 40 million people dealing with the disease, less than 4 hours of dedicated education. Our residents, folks that graduate medical school, that are the junior doctors, well, national surveys show that 62% don't feel educationally prepared to deal with substance use disorder. Okay, let's keep going. Talk about team-based. Our nurses nationally have reported 75% feeling unprepared to deal with patients with drug use or alcohol use. Now, let me just ask the folks here, who do you think is the go-to on our clinical teams for social, substance use, behavioral health issues? Shout it out. Social work, yes, right? 98% of Master of Social Work programs in this country don't require a course in substance use. Everyone's saying wow, right? Great. Keep that wow for one moment. Now, imagine you're that family member, you're that patient, you come into a hospital setting seeking some element of hope. Are we prepared? We're not. Not by our fault, not because we don't want to help. It's just we weren't trained in substance use, substance abuse, or addiction. Again, it looks bad, but it's an opportunity. So we capitalized on this opportunity and we went to our School of Medicine. 4.5 years ago, there's a 2-hour footprint in a 4-year curriculum, 2-hour footprint around addressing substance use. Fast forward to today, we have close to 30 hours dedicated 4-year longitudinal experiences for our medical students, which then we went back into our health system and converted it into residency training for 6 different disciplines. I can name them if you want because they're important. Family medicine, internal medicine, psychiatry. Psychiatry, you think we get trained in psychiatry around addictions? Not so much. Obstetrics and gynecology. I can't remember what I already said. Pediatrics. And one last one, we'll just say I said it. I can't remember what it is. Okay, but it again demonstrates it's a universal problem with our education, not just with our patient population. We've converted to faculty development. Better yet, we use the same slide sets from the medical school out in the community for community outreach. You think that would be too advanced. You're using medical jargon. You know, you need to talk to the quote unquote layperson. Well, unfortunately, we're starting at a negative baseline everywhere we go. We're just trying to bring everyone to this level of understanding that this is a chronic illness and we have every opportunity to be a conduit of hope. So we talked about the framing, we talked about the foundation. Let's talk about the opioid crisis for a moment. Last year, we lost 72,000 fellow community members to drug overdoses, the majority due to opioids. If you combine that with alcohol, 88,000, we're talking about 3 times the number of deaths of the Vietnam War. So 60 years, let's pretend, 60 years of the Vietnam War, we pretty much hit that number last year with just alcohol and drug-related overdoses or related deaths. Shocking, right? Everyone knows Vietnam. I mean, you think bloodbath, you think bad. Yet last year, 3 times. We've surpassed motor vehicle accidents, deaths by car accidents, by suicides and homicides in New York State by our drug overdose rate. And again, majority due to opioids, majority of those due to fentanyl. So what do we do to stop this? What do we do to even make a dent in it? Well, let's not only empower our healthcare professionals, but let's empower our community. And I'm not going to go into much detail because I know this is really in partnership with the state, with the HIV Institute, but I will highlight it's a great conversation to have. It's not about telling folks you need to stop using drugs. It's that, if you are going to use drugs, there's some safety net you could have to save not only yourself, but your family, that school district, that neighborhood. So what do? We took advantage of New York State's amazing policies, and we trained everybody on how to provide education on opioid overdose prevention, recognition, and response. Non-licensed folks can actually educate and dispense because we have a standing order in place. We've given out tons of kits through the emergency department, but the kicker here, one of our emergency departments, the first 3 months, 30% of our kits went out to our own ED staff members. Highlighting again, this is not just a patient issue, but it's an issue we're dealing with as well as healthcare professionals in our homes, in our neighborhoods. We also talk about safe disposal because this is really important, and safe storage. Technically speaking, us just as general community members, we tend to be the worst drug dealers in this country. We give access to so many harsh chemicals to anybody that comes to our house. In the one room, we give people privacy. From our contractor to our niece, a play date, a cousin, whatever it may be, they get to lock that bathroom door and really have at it. Because what do? We hoard. We're keeping this for a rainy day. I may need this medication tomorrow. But we need to actually educate all of us right now. Leave today, do inventory. Tomorrow's the 27th. We have a drug DEA take-back day at 12 of our Northwell facilities. Every police department has this on a daily basis in their lobby. But get rid of the unused and unwanted and expired medications. Why give access? They're hotspots. They're hotspots for accidental misuse. They're hotspots for resale. I mean, unfortunately, again, we're populating a lot of the stuff that gets out there. So talking about safe disposal, we're also implementing or installing these MedSafe units. It looks like a mailbox. Don't put your mail in it. It looks like a mailbox, but they're in our lobbies. So people can dispose of anything they don't need when they're coming to visit their family. If anyone's ever had a family member in hospice and they pass away and you go to their house to clean up, or the hospice, they're loaded with unused medications. We throw that in our water stream, which, by the way, New York, I don't know if it's the right building to say it, but the number one pollutant is medication in our water. So we need to figure out and discuss with folks how to safely dispose. This is NCAP. I won't go. I think you're going to go over this. Or no? No. Okay. So let me tell you right now. If you didn't get an naloxone rescue kit from the folks from Zucker earlier, you can walk into over 2,000 pharmacies in New York State. If you're insured, $40 of the copay is waived if they're part of this program. Majority of the pharmacies have a standing order in place as well, so you don't even need a prescription. We educate everyone about this program, especially our employees. So we don't need to wait to have an event like this. We don't need to wait to get into an emergency department and be offered one. We can walk into a CVS, theoretically, walk into a CVS, ask for naloxone, walk out with probably not paying anything. It's the NCAP program. You can Google it. It's a great service. So let's go to this realization again that any clinical setting, but let's focus on the ED for a moment. Any clinical setting could be the initiating location for addiction treatment. And the way that we have started to do this in 3 different pilots, one in Staten Island, one at Long Island Jewish Medical Center based in New Hyde Park, as well as out in Southside Hospital in Bayshore, what we've done is really educated our frontline prescribing teams, so our docs, our PAs, and our NPs, that there is a medication out there. If you haven't heard about it, it's called Buprenorphine, that can help people that are dealing with opioid use disorder. And what we found with these learning laboratories, based on experiences from many other folks around this country, we didn't develop this, but we definitely borrowed and worked in partnership with them. But really what we're trying to do is look at this as if someone is coming in with, as Dr. Delman said to me before, a diabetic coma. Look at this as someone coming in with a heart attack. Put an algorithm behind it. Put science behind it, and actually prevent the continuation of a process. Support them with medication if they're interested, but start it here as opposed to relying on someone getting into care 2 weeks downstream or 3 days downstream. So to date, we got the 3 pilots going. Thank you, that's my time, but I'll finish in a second. I don't trust myself, as you can tell. But what we've done is now built all these partnerships, Project Connect being one of them. I'm sure you guys saw the press release the other day for New Hope, a crisis stabilization center. Anyone here from New Hope? What's up? Okay. Crisis Stabilization Center in Freeport. You know, trying to streamline folks from our emergency department setting over to care. Care that is well managed, care that is better assessed than in a chaotic environment like emergency department, but it doesn't mean we only have to rely on the second step. Step one starts with us. There's many models out there. We could talk about it in the question and answers, but I just want to highlight this right here. Oh God, I can't show that slide. I got in trouble for this slide before, but I'm going to show it. It's too late. It's on camera too. Wonderful. Okay. I said it before. I think everyone in this room knows. As an industry, there is a big flaw in how we provide some sort of longitudinal experience for folks that are dealing with substance use disorder. So instead of waiting, oh God, are people taking pictures of that slide? Jeez, okay. All right, I'm gonna give my resignation speech after this. But we needed to build a framework. And that framework has to include members of the community. That framework has to include continual engagement. So like I mentioned before, we work with CNG with this huge element of neutrality. And I'm just gonna focus on that word for a moment. Taking an organization that exists in Nassau County, charging them, and not us, but Suffolk County, charging them to do work in Suffolk County, all of a sudden that puts some level of comfort in the mindset, and it should, of the patient, of the healthcare organization, and even of the community-based organization, that whatever we're doing is patient-centric. We're not taking patients from Southside and Huntington and funneling them off to CNG for a business model, but what we're doing is utilizing the experience to continually navigate for patients that live in Suffolk County. And that's a big piece, right? Because we've heard of addiction brokers. We know this is a nefarious kind of process out there. We see this every single day. We need to break those barriers as well, because that stigmatizes and perpetuates folks' lack of attention, lack of action around this topic. So our Project Connect, which has been done in partnership, has been an amazing experience that now we're actually expanding it to other facilities. The same exact model. We're talking to the state almost weekly about this. We just received a state grant to do, in Nassau County in particular, this kind of work with MAT and Project Connect. I just want to show you those figures. I think it's really important for everyone to see engagement to care rates. This is not just engagement, meaning someone picked up their phone call. This is folks still engaged to care because the Project Connect team continually motivates. They use the spirit of motivational interviewing to continue this journey on the path that the patient wants. Okay, so I want to leave it here and I'm going to hand it off, but I really wanted this to resonate with you guys that we started somewhere. And I promise where we started is not on the slide. Where we started was outside the office of the folks that we wanted to talk to, probably 5 days in a row getting our meetings canceled, right? So this looks beautiful now, but we have to start somewhere. And I think it's up to everyone here to figure out who can you partner with. If you guys are community-based organizations, man, call the local hospital and say, by the way, not that we want to come there and recruit, but we want you to know we exist. Because if you're outpatient, most likely not everyone knows you do, because we're only thinking about rehab and detox at this point. So we have a lot planned to do. I won't go into this, it'll come up probably later, but I do want to just end with this. Is that if all of us start harmonizing this language around this topic, we drop terminology from the healthcare perspective of junkie and addict and keep perpetuating the stigma, we can humanize this process. And as we do that, we will destigmatize this process. Finally, we'll be able to disrupt this norm that this industry has been blindly following for years. We'll prepare ourselves to accept this as the healthcare issue it truly represents. We will build partnership within our own professional communities, with our patients, with their families. And better yet, and I promise you this is true, every one of you can be a champion of hope. Every one of you and your teams could be conduits of hope. Because if any of you have ever dealt with substance use in your life, the one element that we always seek is hope. So why couldn't every single hospital, every single outpatient facility, no matter what discipline of primary care or obstetric practice, why can't all of us serve as some level of hope? Thank you. I appreciate it.